To get started here, good afternoon on our last and final day of ICEM. I hope it's been an excellent learning opportunity and networking opportunity for everybody, and everybody's also enjoying Hamburg as well. It is my pleasure to host this afternoon's session here on essentials and hot topics in emergency medicine, challenges and perspectives in modern emergency medicine. I'm just going to outline how this is going to work. We are going to have 3 presenters with topics for you, and we will be taking questions for the presenters directly after their topics. So you guys will get a chance to ask questions of our presenters. Our first presenter this afternoon is Dr. Irena Grad from the University Medical Center at Ljubljana, Slovenia. She's an ICU physician, and she's here to talk to us about hyperoxemia toxicity in the critically ill, enigma, revealing theory.
Good afternoon to everyone. My name is Irena Grad. I'm intensivist, and I'm going to talk about hyperoxemia toxicity in critically ill patients. I'm going to present a theory that could explain the enigma of hyperoxemia toxicity with supporting evidence provided so far. As you may be aware of, hyperoxemia may be harmful to patients. However, it seems that it is not harmful to the same extent in all groups of patients. The archetypal example of a patient in whom hyperoxemia may produce harm is a post-resuscitation patient. So according to these findings, current resuscitation guidelines on oxygen administration during CPR and after achieving return of spontaneous circulation recommend, of course, to deliver highest feasible inspired oxygen during CPR. But as soon as you can measure oxygen saturation reliably through pulse oximetry, you should titrate the oxygen to maintain a peripheral oxygen saturation of 94 to 98%. This is according to resuscitation guidelines based on European Resuscitation Council. However, guidelines from American Heart Association recommend saturation 90 to 98%. If you have blood gas analysis available, you should aim for a partial pressure of arterial oxygen of 10 to 13 kilopascals, which is 75 to 100 millimeters of mercury. By all means, of course, you should avoid hypoxemia and extreme hyperoxemia. Hyperoxemia toxicity in patients after cardiac arrest seems to be dosage and time dependable. Quite interesting. According to studies, hyperoxemia at values more than 300 millimeters of mercury is harmful most, and if it is administered in the relatively early phase after resuscitation from cardiac arrest. Here there is some data from literature regarding this. Here is an article published in Circulation in 2018. The authors were investigating hyperoxemia exposure in post-resuscitation patients and their outcome. And they stated in their conclusion that early hyperoxemia, they meant early by up to 6 hours, exposure after resuscitation for cardiac arrest was independently associated with high risk of death and poor neurological function at hospital discharge. They found that the association with poor neurological outcome began at 300 millimeters of mercury. Similar findings came out from the observational study from Sweden. The investigators took data from their Swedish intensive care registry, and they were investigating if there is a correlation between the hyperoxemia level in patients upon their admission to the ICU and their 30-day survival. The conclusion was that hyperoxemia at ICU admission was associated with lower 30-day survival independently. This was published in Critical Care 3 years ago. Then there is another article, quite recent one from the last year, published in Resuscitation. It was based on a secondary analysis of the TTM2 trial, and regarding the time of exposure to hyperoxemia. They have found that very early hyperoxemia after ICU admission, they meant by very early up to 4 hours, was associated with higher risk of poor neurological and functional outcome after out-of-hospital cardiac arrest patient. And here it is an article regarding hyperoxemia exposure in septic patients. Very interesting finding was that hyperoxemia was toxic to patients in which were in septic shock, but not other groups of septic patients. So only if you were in shock, hyperoxemia seems to be toxic more. I believe there is a physicochemical explanation of microcirculatory dysfunction in critically ill that could explain hyperoxemia toxicity as well. It has to do with physics, and it even shares some similarities with the pathophysiology of decompression sickness in divers. In divers, when they go up too quickly from great depth, gas bubbles occur in their circulation. And it has been shown that the relative platelet count decline after a dive in which bubbles are formed directly correlates with gas bubble load in the diver's body. This is a quite old finding, known for more than 20 years now. It is believed that platelets adhere to the gas bubble blood interface, and possibly also because of gas bubble eruptor damage to the endothelium that causes platelet adhesion, aggregation, activation, and so consumption. It is very interesting that quite a similar phenomenon has been described in ICU patients as well. In ICU patients, the relative platelet count decline after the admission to the ICU directly correlates with their outcome. Patients with higher and more steeper relative platelet count decline after they were admitted to the ICU have higher mortality and worse outcome. This correlation was found so accurate that some authors even suggest using platelet count decline in new sickness severity scoring indexes for ICU patients. Now what I'm going to say, it will sound a little controversial, but I will explain it. I believe that it is possible that in critically ill patients, because of rapid appearance of severe metabolic acidosis, gas bubble forming process could occur as well and cause similar effects as in divers. But let's look at the physics. In divers, when a diver goes down deeper into the sea, because of the pressure of the water above him, more and more gas gets dissolved into his blood and tissues. The concentration of gases in his blood is proportional to the product of Henry's law solubility constant value and the partial pressure at which of that gas he's breathing. This is higher when he goes deeper, of course. As you can see here, Henry's law solubility constant value are very different because gases have very different solubilities. And here it is presented that nitrogen is twice as much soluble than helium. Oxygen is 4 times as soluble than helium. CO2 is a very soluble gas, almost 100 times more soluble than helium. So if there will be 1 molecule of helium dissolved in certain amount of water, there will be at the same pressure 2 molecules of nitrogen and 4 of oxygen and almost 100 of CO2. If a diver goes up too quickly, and gas bubbles form due to decompression in his body, according to ideal gas law, the volume of emerged gas at certain temperature, which is in our body 37 degrees Celsius, and when he comes out, he's at a pressure of 1 atmosphere. This is a constant value. So the volume of the emerged gas solely depends on number of particles dissolved. Here it is obvious why heliox mixture in diver, why they like to use heliox mixture, because for deep, long dive, helium has such a low solubility that not much molecules are dissolved into the blood. So even if he goes up too quickly and gas bubbles are formed, the volume of these bubbles is not large because of low solubility of helium. If I have right and gas bubbles do form in circulation of critically ill patients, because oxygen has twice the solubility of nitrogen, it means that more gas molecules are dissolved into the blood. So if gas bubbles do really are formed, the volume of the emerged gas is bigger in hyperoxemic patients. That's the point. But I have to explain to you how the bubbles are formed because of rapid occurrence of a deep metabolic acidosis. Gas bubbles evolve in a solution in a process called nucleation. They are much more likely to occur at imperfections on the wall of a glass, or if you put a finger into a liquid, because there are many imperfections on our fingers. This we call heterogeneous nucleation. Higher levels of energy and higher level of supersaturation is needed for homogeneous nucleation to occur, which means de novo occurrence of gas bubbles in a solution. If we cause an acidification of a solution that contains bicarbonate anions, which blood of course is, gas bubbles evolve because of supersaturation of CO2 in that solution. Normally we have in blood the concentration of bicarbonate anions around 24 millimoles per liter. And the concentration of bicarbonate is always related to the amount of dissolved CO2. Because of this reversible reaction, these amounts are related. And it is also obvious from the Henderson-Hasselbalch equation that when pH goes down and bicarbonate concentration goes down, that means that this reaction is forced into this direction towards production of CO2 actually, and gas bubbles can be formed. Gas bubbles are formed due to CO2 supersaturation at first, but then according to Henry's law, other gases diffuse into these bubbles as well. That mechanism to me is even more obvious when looking acid-base physiology through Peter Stewart's approach to acid-base analysis, which I really like so much. According to him, pH, which reflects the concentration of hydrogen ions, is determined by three independent variables: strong-young difference, concentration of total weak non-volatile acids, and of course there is a respiratory component with partial pressure of CO2. Here it is a Gamble-Graham presentation of a normal state. Gamble-Graham is sort of a graphical presentation of ionic composition of fluids. And according to the law of electroneutrality, every solution on this earth, maybe sea, glass of water we are drinking, and our blood as well, has to contain the same amount of cations than anions. And here it is obvious. If we add some other anion, let's say that lactate emerges in a circulation because of a resuscitation or some other reason, actually to maintain the electrical neutrality, some of the other anions has to go down. And what we observe is lowering of pH and lowering of bicarbonate concentration. Illustration of this gas bubble forming process you can all try with a simple home experiment. If you open a bottle of carbonated drink, this is an illustration of decompression. Carbonated drinks are made so they are made under pressure. Here it is a pressure of 3 to 4 atmosphere and pure CO2 is here inside. So much CO2 is dissolved here. When you open such a bottle, the pressure goes down to 1 atmosphere, and in our atmosphere is 0.04% of CO2. According to Henry's law, supersaturation of CO2 evolves and gas bubbles emerge out of this bottle. If you pour a lemon juice or a vinegar into a glass of Coca-Cola, you will see thousands of small bubbles emerging out of it. Because whenever you have CO2 in a solution, as I showed before, it is always in correlation with the concentration of bicarbonate. So every solution that contains bicarbonate contains CO2 as well. As you know, the main path of CO2 to be transported from tissues to lungs is actually as bicarbonate anions. As we know from physiology, CO2 goes into red blood cells where it is transferred to bicarbonate, and then there is this chloride shift, and 70% of emerged CO2 is transported to the lungs as bicarbonate anions, much less than carbamino group or as dissolved CO2. If there is a process in blood that lowers our bicarbonate levels, I believe that process is severely disturbed, maybe disturbed. So to check our theory, I started to observe my patients, and I wanted to check if the severity of metabolic acidosis in patients upon their admission to the ICU correlates with the platelet count trend in the following days. And I always see this. Here we have base excess values, which is a measurement of the severity of their metabolic acidosis, and the platelets goes down every day. If you're not interested in this, if you don't look at the values, actually you don't see it, because platelet count may be still normal, but you see the trend. We performed a simple observational study at our ICU. It was a retrospective observation of all the admitted patients in a 1-year period. And we checked the statement I said before. We checked if the severity of their metabolic acidosis correlated with the platelet count decline. And as you can see here, we have found that there is a correlation. So that's the end of my presentation. Yes. Thank you.
Thank you very much, Dr. Irena Grad. We actually have time right now for questions. So if anybody has a question, you can raise your hand. I've got our trusty portable microphone, and then you can speak into the microphone, and we can share any comments that you have and questions that you have for Dr. Irena Grad.
Mm-hmm. Yes. Hi there. So I guess my question, and thank you for sharing your research here. I'm just wondering about the sort of clinical applications of this. And of course, it's still a little bit early, I'm sure, to say. Other than avoiding hyperoxemia, would you consider adjusting how, for example, you might administer bicarb or other, for example, cationic crystalloids or electrolyte solutions, that sort of thing?
Thank you for your question. Yes, one of the things that I have seen that it might help to patients is maybe the usage, maybe the usage of antiplatelet medications as a prophylaxis for thrombosis, because it has to do with platelets. And I spoke to some traumatologists, and they told me, and I saw many articles regarding this, that maybe anti-platelet drugs should be used instead of, I don't know, heparin, I don't know. Yeah, maybe, yes. But what else? Yes, I really believe that that could be the possible explanation of it. But it's a theory so far, maybe even hypothesis, because it is not, of course, widely accepted. As you may know, so far they are explaining hyperoxemia toxicity with free radical species, which, of course, I agree with that. Free radicals are formed and they do cause harm. But instinctively, I would imagine that free radicals would produce higher aging or higher susceptibility to get a cancer, not such an immediate intense harm that was actually proved. As you can, if you saw that that articles, they are talking that hyperoxemia is actually toxic to patients who were in shock. Probably it wouldn't be toxic for me now to breathe 1 hour of oxygen. And all the studies I have read are telling the same story. Hyperoxemia is toxic when you are in shock. Otherwise, not so much.
Maybe a correlation with DIC, that sort of thing.
Yes. So my point is that if you're in shock and you are in severe metabolic acidosis, gas bubbles are produced and all this, otherwise not. So,
Thank you very much for sharing your research and your findings and your suspicions with us. I also really appreciated your slide with the pop, and now I can think, wow, that might be actually happening in my blood every time, and you know how that applies. We'll move on now to our next speaker. Thank you very much, Dr. Irena Grad. Our next speaker comes from the Chinese University of Hong Kong and is Dr. Colin Graham, who is here with us today, who will be speaking to us with regards to acute aortic syndromes and the diagnostic pitfalls and strategies that can help us with our patients.
Hello everyone, can you hear me? Fantastic, good afternoon. You all alive? Sure? I need to keep you all alive because tonight Scotland are playing in the World Cup. And we need your support. We desperately need your support. We haven't been in the World Cup for the last 20 odd years, 25, 26 years. Come out and support us. We need everything you've got for us. But that's not what I'm here to talk about today, unfortunately. I'm here to talk about acute aortic syndromes. I am very lucky to live in Hong Kong. It's the best place in the world after Scotland. And I work at the Chinese University of Hong Kong, and I work with a great bunch of people. I have no conflict of interest to declare here, but this is my research team, and we're very fortunate to work with a bunch of committed clinicians and researchers from cardiology and mostly cardiothoracic surgery. But one of the things I'm going to focus on today is really about imaging as well as biomarkers, and I'm going to take you on a gallop through acute aortic syndromes. So, I'm not going to do this in detail because I know I'm preaching to the converted. You are all aware of acute aortic syndrome. When did you see your last one? Have you seen one in the last month? Give us a show of hands. That's pretty good, actually. That's pretty good. Not a common condition. You've probably suspected more than you've seen, which is what I would expect. But they are, in fact, very, very rare. How many of you can get a CT angio at the drop of a hat? Stick your hands up for me. Wow, you are so lucky. About 50% of our requests for CTA in Hong Kong are refused in the public sector because we do not have resources to do them. And I'm lucky, at least I can request it. There are many countries, many facilities in the world which don't even have access to CT. So we've got to think about this in perspective. Biomarkers are something I'll come on to, and point of care ultrasound is another thing I want to discuss at some point. But we all know that AAS is a broad term encompassing a range of pathologies, but all basically from disruption of the aortic wall leading to a leak within the aortic wall and stripping of the different layers and malperfusion syndromes that come from that. And obviously, ultimately, they can reflect, they can become a free rupture either into the pericardium or into the mediastinum or elsewhere. But identifying it is very challenging. The prevalence is extremely low. In Hong Kong, we see about 2 cases per 100,000 people, which means we have about 150 cases a year. Now, to put that in context, Hong Kong has 17 public hospital emergency departments. That means your average department is going to see 10 a year. Your departments obviously will vary in size. My department sees 150,000 patients a year. If you're working in a department that has an attendance of, say, 20% of that, 30,000, which is not uncommon in this part of the world or North America, you'll be seeing 2 or 3 cases a year. Tiny, tiny, tiny numbers. You're looking for a needle in a haystack. But that needle is very self-destructive and patients die of this, and we know it's a time-dependent diagnosis. The most frequent symptom we're all taught at medical school is chest pain. But in fact, it's incredibly variable. We know that in the Asian population, in the broadest sense, not just Chinese, but across Asia, 16% of all acute aortic syndromes do not get any pain at all. 0. They present with dizziness, sweatiness, I don't feel well. How are you supposed to make a diagnosis when you don't have pain? So we have a particular challenge in that respect, but again, the symptomatology is very variable. But in Hong Kong, we know our patients tend to report much less abrupt pain. We're always told that the pain is tearing and terrible and abrupt. Not true, depending on which part of the world you're looking in. And obviously the symptomatology overlaps with lots and lots of other conditions that we worry about, particularly ischemic heart disease and the like. As I mentioned already, our challenge in Hong Kong and in many other cities is that we don't have easy access to CT. CT is a very tight resource in many settings. I remember years ago doing a talk in Hong Kong, and a colleague from Boston was there. And this was 20 years ago, and I was so proud of the fact we'd got our CT scanner in our emergency department. And he looked at me and he said, "Your CT scanner?" And I said, "Yes." He said, "How many have you got?" I said, "I have one." It's brilliant, because we were the first in Hong Kong to get a CT scanner. He had 7 in the ED, not in the hospital, in the ED. Yeah. So we live in different worlds, and we have to recognize that access to imaging is a particular challenge. We also know that even with access to imaging, initial misdiagnosis rates are high. And in our recent study that we did in our centre, we missed 31% of type A dissections in the ED. Some of them were picked up in the medical wards because they were admitted with non-specific symptoms or chest pain. Some were not picked up until the autopsy lab. So we have a problem. But we also have to ask ourselves, what does everyone want? And I'm going to take 3 little examples here. This is one of my colleagues in cardiac surgery. He actually painted this picture himself. He's a phenomenal artist as well. But what he wants, what his team wants, is a diagnosis on a plate. They want to be sold the platter that says, "Here is my aortic dissection patient, please operate on them and fix them." They have no interest in anything else in my setting. I'm not saying that as a criticism, it's just a reflection of the way they work. They expect to be given a diagnosis and asked about a treatment option. But they really don't want to know about query acute aortic syndrome. They want to know about definite acute aortic syndrome. That's not what I want. I obviously want to find out who has an acute aortic syndrome. But I also want to be sure about patients who don't have an acute aortic syndrome so I can safely send them home. And cardiologists and cardiothoracic surgeons have very simple, basically bipolar reactions to this. Do a scan, or do the scan, find out. But the third person who I've not given a slide to is the radiologist. Now again, I have to be careful here. My sister's a radiologist, so I can take some liberties, but not too many. I might die. But the reality is radiology is overburdened in most centres. They can't scan every patient. And as I've said already, our scan rate has doubled in the last 10 years, but it's still microscopic compared to what it should be. And if we scanned every patient for acute aortic syndrome, my department would stop functioning. It would just cease to function because we are already running 24/7 with the scanners that we have. And I think many of you will be in similar scenarios. So we've got to find ways to risk stratify. We've got to find ways to make sensible decisions about who we image and who we don't image. And this is where alternative tools can help us. How many of you know of and use ADDRS? Can you give me a show of hands? Right, that's super. That's about a third of you. Well done. I asked a convention of cardiologists this a year ago in Hong Kong, and the answer was 0. So this is not a well-known tool. It is not a well-used tool, and honestly, it's not a particularly well-validated tool in many settings. Its simplicity is very useful, and we should be thinking about scanning everyone who has a score of 2 or 3. We should probably not be scanning people with a score of 0, although you'll still miss 1 or 2, but it is very small. But those with a score of 1 are the problem, because we really don't know what to do with them. And if we scan all of them, we'll cease to function. But if we don't scan some of them, we'll miss important diagnoses. So we have a problem here. So we've gone back, and I'm going to share 2 bits of work briefly with you on what we've been doing recently. We've looked at the literature. I mentioned some of this morning at a previous talk, and we've looked at different scoring systems. The ADDRS you've got there, I'm not going to go into it in detail. I'm just going to show you a couple of them. ADDRS is there, and we've got aortas, which is another well-known score. Another one, the Canadian one, is called the RIP score. I particularly like that name. It's nice, the RIP score. It should remind you of the type of pain you get, ripping. But again, remember, you don't always get that pain. The problem with all of these scores is that the more sensitive you make it, the more scans you have to do. So we've looked at this in terms of different thresholds. We've also added in D-dimer, which has got good potential to be used as a rule out, not as a rule in, as a rule out, because it's highly sensitive. But again, you have to ask yourself, what assay do you use, and where do you set your threshold? Most of us have been, through our experience with thrombotic illness, with DVT and PE, would say 500 is our level to maximize sensitivity. But if we set that level at 500, we'll be scanning thousands more patients. There's some evidence from my part of the world, from the Chinese mainland, that 2000 might be a better level. But again, that depends on the assay you do. Each assay is different and has different behaviors. And it varies also whether you use a lab-based assay or a POCT assay. And obviously many of us like POCT because of its speed. But that then also adds to the scan burden. So we have challenges here in terms of working out where to go. But if we use ADDRS, if we use D-dimer at a threshold of 500, and if we use POCUS to rule in, D-dimer to rule out, then you can approach sensitivities of 100%, about 98.6, 99% sensitivities compared to the gold standard. So the biomarker I've mentioned already is D-dimer. It's common. It's in most people can access it, can use it. We've been mentioning so far D-dimer as a rule-out biomarker. What would be really ideal is if we could also have the troponin for aortic disease, a rule-in biomarker as well as a highly sensitive rule-out. I've taken this slide from a recent review in the European Heart Journal of Acute Cardiovascular Care, and this has, I don't know, a dozen different markers on it, including the ones we would expect, D-dimer, aggrecan. The last systematic review I looked at on this listed 201 candidate biomarkers. Now, if any of you are philanthropists and have lots of money, I'll take any money you've got to test those 201 biomarkers. But the problem is, with 100 cases a year in Hong Kong, it's going to take me 20 years to get enough patients to do that research. So even if we want to do that, it's going to be hard because of the rarity of the illness. But clearly the ideal would be to have a rule-in marker as well as a sensible, rule-out biomarker. See, even the dog agrees. But we did start to look at, I've never had competition from a dog before. This is a new one for me. Yeah, keep going. We did a little study in the last year or two looking at D-dimer, but also looking at aggrecan, which is a muscle marker, a proteoglycan marker, and desmosine, which is a cross-link component in elastin. And there was some evidence that desmosine had potential as a marker for acute aortic syndrome. And there's been good evidence from this part of the world, from Germany, from Berlin, that aggrecan would also have some impact. And we wanted to see if we could use that combination of markers and ADDRS to try and risk stratifying a group of patients. So it's taken us a long time to do this study. The results I'm reporting today are on 28 patients and 28 controls. We've just in the last week, when I've been over here, managed to get that number up to 47, which is where we think we need to be. I haven't got those results yet, obviously, but we'll be doing that in the next month or so. But essentially, we did a age and sex matched control group. We compared them and we wanted to see where this went. And I must acknowledge the funding we got from the Hong Kong College of Emergency Medicine to do this work. In essence, without boring you with all the numbers, there were very few important differences between the two groups, except, of course, the non-acute aortic syndrome group had an ADDRS of 0 versus more than 0, more than 1 for 61% of the patients who had that. We saw significant differences with aggrecan and with D-dimer. Desmosine did not seem to add anything in this group. We obviously combined these biomarkers to try and optimize their performance as much as we could. And what we found was that aggrecan and D-dimer with ADDRS more than 1 was as good as all three. Desmosine really did not add anything to what we were trying to do here. And using AUC curve there, again, the yellow unfortunately doesn't come out too well, but the yellow one was as good as the purple one, which had everything and had 1 less biomarker there. So in essence, that combination came out with a 95% confidence interval of about 0.81 to 0.97. Pretty good. Not perfect. But again, we're hampered by relatively small numbers. We hope we'll improve this when we look at our bigger data set. So the combination could improve that performance. Again, though, what we need to do is find a way of doing that assay much, much faster than we do at the moment. Because at the moment, it's all in the lab. And so we need to think about where we go next. Should we be using D-dimer as a way, POCT in particular D-dimer, as a way of selecting people for scan? Part of the reason D-dimer has become important in this area is because the data sets that have been used have mostly come from our friends in North America, where your D-dimer is high and you get a CTPA. Half of those CTPAs don't show any pulmonary embolism, but they do show an aortic dissection. But these studies were not designed to identify aortic dissection. They were they were used to find PE. So it's the wrong question. So we need to go back and look at the strategy as much as the diagnosis. And of course, in terms of throughput, that's our other question. It's all very well to do every test on every patient, but our departments will cease to function. We need to find ways for patients to flow through in a sensible way without missing florid pathology. So we're aiming to reduce this misdiagnosis of a rare but lethal disease, and I hope that's shed some light on where we're trying to go with this at the moment. I'll be very happy to take any questions, and thank you for staying to the end, and thank you for your support of Scotland tonight.
Thank you very much, Dr. Colin Graham, for sharing your thoughts and your research with us. We have time right now. We're going to go right to questions before our last session. Do any folks out there have any questions or comments they want to share with us or discuss with Dr. Colin Graham?
I was terrified you all.
Will you catch the microphone?
So previously I've had patients with Ehlers-Danlos who have had other vascular injuries who've come in with a classic pain but young, don't want to scan them repeatedly. Sure. And D-dimer didn't really have that evidence base. Are we now at the point where a negative D-dimer in that patient can spare them a CT, because these are people in their 20s, 30s?
So that's a super question. I think there's two populations out there. I think there's a connective tissue disease population, and every time I talk to our cardiac team about them, they have a reflex scan them. There's nothing else that can rule it out in those patients. But I think they are different from the slightly older 40s, 50s, 60s atherosclerotic population that we see most of this in. But I think for the connective tissue, they're so high risk.
You'd still scan.
I think it's reflex at the moment. Now, does TOE have a role to play? I think it probably does, but again, it's access. Yeah. And we had a patient recently with a connective tissue disorder who refused to have a CTA. Yeah. Understandably, he had a few before, and the problem then was, what do you do next? And MRA and TOE are all lovely, but we couldn't do it in the ED.
No. And if there's no other questions, I've got one other one.
Sure.
Okay, so the other issue I found with aortic dissection is blood pressure control. What is an accurate blood pressure, especially when you have dissected down all of your main vessels?
Totally.
Because you just don't know what that central perfusion pressure is.
Absolutely.
And you're left with someone who looks shocked peripherally, but very probably still has a high pressure at their aorta.
Totally agree. Again, I think this is a very difficult question to answer, and I think there's two bits to it. I think what our surgeons do and what our intensivists do, and we've followed this, is a right radial line. I think that's the only solid thing you've got. But that's the issue, is it depends a bit on where your anatomy is. Now, I think there have been some reports of ultrasound-guided central pressure estimation again, but it's very early, it's very preclinical, and at the moment I wouldn't trust it.
And it's outside my POCUS skill set.
Totally. So I think to me, at the moment the best thing is not invasive right radial artery, but I don't think it's perfect, and I don't think we have an answer to that. But I think the problem, as you say, is once you've stripped off all those arch baroreceptors, you're in trouble, because the body itself doesn't know what it's doing.
Yeah. Cool.
Thank you.
Thank you very much. We have time to take one more question if anybody else has a comment or question for Dr. Colin Graham. All right. Well, thank you very much again.
Thank you.
And now I think it's time for our last talk. This is my pleasure to introduce, and it's my first time meeting and I'm going to exercise some courage. Rapeeporn Rojsaengroeng. Correct? All right. Is coming to talk to us. And welcome to my show. Yeah. Okay, and you can speak into it, and I think they'll nod and tell you they can hear you.
Did you hear me?
All right.
Okay.
So Rapeeporn will be talking to us on the study of the River Emergency Medical Operations Unit along Chao Phraya River. Well, thank you very much for coming and joining us. We're just going to get your slides loaded up right now, and they should be up very shortly. Oh, you're going to have control there.
Okay, I'm Dr. Rapeeporn from the Washira Hospital, Bangkok, Thailand. I will talk about the water-based EMS unit along the Chao Phraya River in the Bangkok. And I declare that I have no conflict of interest. First of all, I cannot swim. Actually, I deal with the water-based EMS at the first time. I am afraid. However, the show must go on. Okay, and the Chao Phraya River is the main river in the Bangkok. Before the 2008, the volunteer help the victim, and the response time is around 20 to 30 minutes. The response time is to start from the call to scene. That means there is near 0% submerged survival. Nowadays, Bangkok Dispatch Center set up some system that can decrease the response time to the 8 to 10 minutes. And there are a lot of stakeholders to join in the Chao Phraya Emergency Response Network. Bangkok Dispatch Center act like the central command. They cooperate with the advanced EMS unit, volunteer basic unit, and for the search and rescue, they will deal with the fire and rescue department, Royal Thai Navy, and for the waterway management about the traffic, they deal with the marine department, and about the law enforcement, they deal with the marine police. So many stakeholders. And the threat is water-related injuries are the second most common cause of accidental death in Thailand. Bangkok ranks third nationally, and clinical survival in drowning incident is strongly associated with the submersion times under 10 minutes. Today I will talk about the description of operational characteristic and system structure of advanced water-based EMS unit along the Chao Phraya River in the Bangkok. And I did the retrospective study that I reviewed the data during the 2021 to 2022, and I received the data from the Bangkok Dispatch Center and the 3 advanced water-based EMS unit in Bangkok. And Bangkok Dispatch Center separate the river into the 3 zones. Upstream is under the Hospital A, midstream is under Hospital B, and downstream is under the Hospital C. And this is a EMS unit general characteristic. Hospital A is the Washira Hospital, is my hospital. It is the university hospital, and we have the 2 speedboats and pier. Hospital B and Hospital C they are the tertiary hospital, and just only the Hospital C, they just dock the boat at the private pier. That is inconvenient to do the emergency rescue. And following the operational readiness, Hospital A is fully equipped, including the clinical capability, advanced airway, standardized equipped storage. Following the operational cadence, Hospital A operate all days, and we have like proactive maintenance system, and we have the rescue training every year. However, we have a few guideline protocol, including the safety protocol. Following the hospital B, they lack of the maintenance system, and they lack of the rescue training, including they lack of the clinical guideline and safety guideline. Following the hospital C, they don't have anything because they just operate in the special event. They don't have the doc. They just use the private pier instead. And I will show the Washila water operation. This is a hospital A or Washila hospital. This is like Washila symbol. We treat the patient by heart. And we make the simulation training every year, at least once a year. You see the walkway, it is not good enough. And in the Bangkok, if the patient need the water emergency rescue, they can call the Bangkok Dispatch Center, Bangkok Fire and Rescue, and call Hospital A call center. And the water team can receive the news from the water line group that is established by the volunteer network. Bangkok Dispatch Center will receive the call. You see the number 1. We receive the Bangkok Center receive the call and triage and dispatch. And they will send the basic water boat or advanced water boat to go to help the patient. Then Bangkok Dispatch Center will coordinate to send the patient from the boat to ground ambulance and to the destination hospital. Finally, the Bangkok Dispatch Center will ensure the quality control and manage financial compensation. And Bangkok Dispatch Center need to do the unified coordination flow, including coordination with the 3 volunteer foundation, 3 hospital advanced EMS, and if we need some specialized equipment, we will call the fire and rescue department and the marine department. We need to guarantee the response time around the 10 minutes because that is the optimal survival. And there are so many the physical disconnect, such as unstable pontoons, steep inclines, narrow pathway, and obstructed routing to the emergency department. Washila Hospital or Hospital A would like to decrease the response time by setting the dual dispatch intercept model. When we receive the call, we send the rescue boat together with the ground ambulance to the interception point that we can help the patient and can decrease the response time. You see, we can decrease the response time to 8 to 10 minutes. 8 to 10 minutes. And these are the unit readiness comparison. Hospital A operate the 24 hours, and we record the data via the paper. And the weakness is we have only a few quality control. Following the Hospital B, they record the data via the paper, and sometimes they lost the data. Hospital C, they they don't have the dock and some advanced equipment. If we require moving forward from the fragmented hospital initiative to the unified accredited system standard, we need to start from the infrastructure integration, that we need to integrate the peer, board and personnel. Then we need to make the unified digital reporting that can track to the secure funding and drive quality improvement. Finally, we need to have the CAMS global accreditation to align the entire continuum of care. For the infrastructure, we need to correct because we lack of the we have the incomplete and paper-based reporting, leading the data black hole, and we lack of the unified GPS and communication platform between hospital, board, and other agency, and there are disparity in the advanced medical tool and standard training protocol. Following the water system in the Bangkok, Marine Department is responsible for the vessel license, pier safety, and professional boat operator certificate. Bangkok Dispatch Center is responsible for the pre-hospital standard, healthcare personnel certificate, and medical equipment oversight. However, there are a lot of systemic frictions, such as zero marine insurance coverage for the rescue vessel, silo hospital budget dictate the reactive maintenance, and some devices is lacking, such as the missing spotlight and fire distinguisher, and a few guideline protocol, including the lack of the infection control protocol. Data backhaul, only 60% of missions are fully recorded. And if we would like to move forward, we need to start from the infrastructure integration, unify digital reporting, and put the CAMP global accreditation to the system, that we can align the entire continuum of care. This is the last page. If we would like to strengthening the Bangkok's water-based EMS, we need to require the infrastructure improvement and implement the CAMP's global accreditation and standard training, and transitioning to the electronic reporting for real-time monitoring. That's it. Okay.
Thank you very much, Dr. Rapeeporn, for sharing your experience with the marine rescue for drowning in Bangkok. We have some time right now, and we can take questions or comments for Dr. Rapeeporn. Does anybody here have a comment or question they would like to? I won't have to throw it at you. I can pass it to you if that's what you're intimidated by. Questions or comments? Maybe I'll take a moment, and if you guys can come up with a question, I'll share just a comment myself. I really appreciate this presentation. I mean, we're here at a global emergency medicine conference, and we're all experts and continuing to develop our expertise and, you know, ABCD care. But at the same time, when we go home, we all serve our own patient populations with very specific needs. Like where I come from, Toronto, Canada, yes, we're on a body of water. Yes, we see drowning, but nowhere near the level you're seeing. And we're nowhere near the level of considering how to improve patient care and early interception the way you have, and considering even things, and I can understand the way when you're explaining, oh, you know, if the pontoon is unstable, if the incline's too steep, this is going to, I mean, that's going to result in lives lost, and I'm not even thinking about that because, you know, the greatest needs in my population are different, but it shows how at the same time we have all such similarities in our training and giving care, but we all still serve such unique functions for our patient group. So this is a really great reminder of that in the global emergency medicine community for me. Anybody else, any other comments or questions at all? All right, well, I'm going to give some time back to you. You can enjoy Hamburg and enjoy the rest of the conference.